Hello students, मेरी तरफ कर दो इसको. हाँ. Hello students, so welcome to today's radiology class. In this class we'll discuss the top 50 images for your upcoming INI-CET. Let's discuss these top 50 images and we'll try to finish it in 60 minutes because I know INI-CET is just around the corner, only around 20 days, less than 20 days left for you, and so the adrenaline rush would be at its peak, the anxiety would be at its peak. So in today's class, just relax, okay, even if you're not able to answer all the images, it's totally fine. Just take it as a passive income because right now what we need, we need confidence, we need to be strong in our studies, we need to be strong in our belief that whatever preparation that we are doing, okay, we don't know what the future is, we don't know what the result is, but हमें अपनी preparation करनी है, ये हमारे हाथ में है, हमें अपनी प्रिपरेशन करनी है. सो आज की क्लास में कोई असेसमेंट नहीं होएगा, आज की क्लास में कोई जजमेंट नहीं होगा, जो आपको आंसर जितना आता है दैट इज़ वेल एंड गुड. ठीक है, सो लेट्स स्टार्ट. सो जस्ट बिफोर स्टार्टिंग, just a motivational quote for you that see, whenever we are predicting, whenever we are studying for any entrance exam per se, you know, we do not know what the rank will be and nobody can predict what your rank can be. And so all you can do is put in your effort, all you can do is put in the best that you can, and that will only tell you that that will only can predict your future, that can only predict your good rank. Now let's come to the first image. So we'll discuss image and few questions related to it. So what is the modality in this image? Yes, so it is a 3D ultrasound. So it is a 3D ultrasound. ठीक है, इसका live chat on कर देना. And what is it used for? What are the uses of 3D ultrasound? Yes, so one of the uses is for Mullerian anomalies. Okay, for Mullerian anomalies, 3D ultrasound is the investigation of choice. Now, apart from 3D ultrasound, can we use some another modality for Mullerian anomalies? Yes, we can use an MRI. If both MRI and 3D ultrasound are given in the option, MRI would be a better investigation. Now, why do we say it is a 3D ultrasound? Because it is looking like an ultrasound picture, but we can see the external contour as well. Okay, whenever we want to see the external contour of a structure on an ultrasound, that type of an ultrasound is a 3D ultrasound. Remember, right? Now, apart from Mullerian anomalies, can we use it for some other pathologies as well? Yes, we can use it for fetal anomalies. And which type of fetal anomalies per se? So some facial anomalies. Okay, so for example, we want to see some cleft lip, cleft palate. These sort of things are better seen on a 3D ultrasound for fetal anomalies. Now, when it comes to Mullerian anomalies, which is the gold standard. Now, if the gold standard is asked for Mullerian anomalies, remember the gold standard for Mullerian anomalies is a hysteroscope plus laparoscope. Hysteroscopy plus laparoscopy. Okay, because based upon both these things, so hysteroscope will let us know the cavity, whether there are two or one cavity inside the uterus, and the laparoscope will tell us about the external contour. So hysteroscopy plus laparoscopy is the gold standard. So good evening everybody. Yeah, nice. So let's move on to the next image. So few anatomy questions I have just put because anatomy questions are also asked based upon an anatomy radiology correlation. So which is the structure marked? So tell me this structure, the first structure. Okay, the first structure. Yes, this is the, what is the structure marked? Okay, yes, this is the Meckel's cave. This is the Meckel's cave. ठीक है, what does it have? It has the Gasserian ganglion, it has the ganglion of the fifth nerve. And what is the second structure marked? This second structure, it is a part of cerebellum, right? It is a part of cerebellum. Which part? Since it's a midline part of cerebellum, yes, you're right, it is vermis. It is the vermis of cerebellum. Now, for something for you to read on your own, posterior fossa cystic structures. So we are talking about Dandy Walker, we are talking about cerebellar hypoplasia. These things you have to read on your own. I am giving you as a homework. Okay. Now let's move on to few another anatomy questions. So which is the structure marked in the upper image? So it is a coronal section. Okay, which sequence of MRI is this? Guys, which sequence of MRI are we talking about? Yes, okay, this is a coronal section first. This is a coronal section of MRI and a T2 weighted image, right? Because the CSF right here is bright. T2 coronal image, and we are seeing this medial structure in the temporal lobe that is marked by the arrow. This S-shaped structure is the hippocampus. This is the hippocampus, right? Now in the lower down image, what is this image? First of all, it is an MRI, right? It is an MRI, and which sequence of MRI are we seeing here? So first of all, this is a sagittal image. Okay, this is a something wrong with the pen. This is a sagittal image and an MRI, and this is a T1 weighted image. Why? Because the CSF that you see here, the CSF in the basal cisterns, like this whole CSF is black. Also the corpus callosum. The corpus callosum is a white matter, and white matter is appearing bright. So this is a T1 weighted image. And what is the arrow showing? Which structure is the arrow showing? The arrow is pointing towards fornix. Okay, so an anatomy question can be asked based upon Pappe's circuit, that which structure is marked, which is a part of Pappe's circuit. So remember, fornix is marked. Where do you see it? You see it below the corpus callosum, going and inferiorly ending in the mammillary bodies. Okay, right. So it is a sagittal T1 weighted image. Good. Now let's move on to the next image. So some anatomy questions again. So let's just label all the extraocular muscles really quickly. So yes, this is the, which is this nerve that, which is this muscle that I am labeling. This one. This top image, this muscle is the superior rectus, right? Now which is this muscle? This is the lateral, so this is the lateral rectus. This is the inferior rectus, and this is the medial rectus. Now which is this small chotu C image? Which is this small chotu C muscle that I am labeling here? Okay, this you are right, this is the superior oblique muscle. Now we know superior oblique is supplied by 4th cranial nerve. The lateral rectus is supplied by the 6th cranial nerve, and rest are supplied by the 3rd cranial nerve. Now some important pointers regarding a medicine radiology correlation. Remember, lateral rectus is the last muscle to be involved in thyroid ophthalmopathy, which is, and also remember, lateral rectus is the muscle which is more commonly involved in IgG4. Okay, IgG4 mein lateral rectus is first involved and lateral rectus is last involved in thyroid ophthalmopathy. Okay, now let's move on to the next image. So identify the labeled structure. Few anatomy questions. Okay, I'm waiting for the reply. So which is the structure which is marked here? Come on, tell me which is the structure that I've labeled here. First of all, what is this image? Which modality is this? Yes, this is a MRI of knee MRI, and this is a sagittal image, sagittal section, and I have labeled a cruciate ligament. Right, and since it is attaching posteriorly on the tibia, so this is the PCL. This is the PCL, or the posterior cruciate ligament. Now on this sequence, I want you to label, this is the patella, the femur, the tibia. This right here is the quadriceps tendon. This is the quadriceps tendon. And this right here, this structure, this is the patellar tendon. Right? Now some important signs related to PCL. Now, if you see two PCLs, one atop each other, okay, one above, one below. So this is one PCL and this is another PCL. So this is a double PCL sign, a double PCL sign. Now tell me, where is double PCL sign seen? Tell me, where is double PCL sign seen? So double PCL sign is seen in bucket handle tear. It is seen in bucket handle tear of medial meniscus. So this right here, this is the diagrammatic representation. So this is the medial meniscus right here, and you see that the medial part of this ligament. So this is the medial meniscus, sorry for this. This right here is the medial meniscus, and this is the part of the tear which has turned upon itself. Okay, so this is the bucket handle tear, and it comes medially. It comes medially into this intercondylar notch, and hence gives an appearance of a double PCL sign. ठीक है, PCL, double PCL sign, medial meniscus injury. So which type of medial meniscus injury? A bucket handle tear. Okay. Now, which is this ligament? Which is this ligament? Good, it is attaching anteriorly onto the tibia, and you can see very well the dark fibers, okay, the linear fibers of this ligament. This right here is the ACL. This is the ACL ligament, anterior cruciate ligament. And some important sign related to anterior cruciate ligament, sorry. Yeah, so I want you to name this fracture. I want you to name this fracture. This is associated with ACL injuries. Very commonly, around 75% of cases, this fracture is associated with ACL injury. Tell me, which fracture am I talking about? Which fracture am I talking about? Okay, yes, this is ACL. So which fracture is this? So you can see small avulsion fracture. Okay, this is a small avulsion fracture on the lateral aspect of tibia. What is this fracture known as? What is this fracture known as? Yes, this is known as a, sorry for this, this is known as a second fracture, and this is associated with ACL injuries. Now, sometimes a question gets asked that second fracture, okay, second fracture is due to injury of which ligament? Okay, this can sometimes be asked because this ligament was recently discovered in 2017. So, second fracture is actually ALL ligament avulsion fracture. Now, ALL stands for anterolateral ligament, and this ligament is very commonly injured along with ACL because the mechanism of both of these is the same. So this is an avulsion fracture. Which kind of avulsion fracture? This is a named fracture known as a second fracture. Okay. Now, some ACL injuries, ACL tears, how do they actually look like? So you see here that the fibers are discontinuous. You do not see the continuity of fibers very well. See how well these fibers are seen on this image. So very linear T2 hypointense, but here you see that these fibers are not seen. You can see fluid signal within the ACL. So this tells you that this is an ACL tear. So right here, this is an ACL tear. But see this image, the fibers are intact, but you again see this T2 hyperintensity within the ACL. So this is a mucoid degeneration. This is a mucoid degeneration of ACL. And which sign is this? Yes, this is the celery stalk sign. Okay, this is the celery stalk sign that you see with mucoid degeneration. This is the axillary stalk. Now, let's come on to the second image. Now we are done with a few MRI and few anatomy questions. Now we'll come to chest radiology and respiratory radiology, very, very important as far as your INI-CET is concerned. Now, which is this image? Very easy spotter. This is showing a pleural effusion, right? A pleural effusion. And remember, if pleural effusion is sterile, okay, if it is just an exudative or a transudative effusion, this will show an S curve because it is a free fluid in the pleural cavity. But whenever there is infection of this pleura, whenever this effusion is infected, we call it empyema, and then we see a loculated effusion. Okay, this gives a split pleura sign that we have read. Now, which image is this? This is a CT scan, contrast enhanced CT scan, and so this is showing a split pleura sign because of enhancement of visceral pleura and the parietal pleura, which have been labeled by the arrow. Now, on ultrasound, what you get these loculations. You get these loculations within the pleural space. Now, these two tells you that this is an empyema and this needs to be drained. So, treatment right here will be a PCD insertion or a pigtail catheter insertion or a single time aspiration, depending upon what the thickness of this empyema is. So, this needs to be drained either by PCD or a single time aspiration. Single time aspiration or a PCD. Now, let's move on to the next image. So, here we see that one side of the lung is very, very black. It is appearing very black. And you can see the arrows are pointing towards a visceral pleural line. Now, this is an example of a very easy spotter, a pneumothorax. Okay, very commonly seen in trauma settings. So, it can be a surgical radiology correlation type of question in which you are given a traumatic history, a history of trauma, and then you can be shown this X-ray where you will see is blackout lung with the visceral pleural line. Now, which is the best X-ray view? Which is the best X-ray view for this? Remember, an expiratory X-ray. And expiratory X-ray is the best chest X-ray view because that is where you see this visceral line very well. Now, the best investigation, remember I told you in a radiology class that whenever we are talking about air, the best investigation will be a non-contrast CT. So, be it pneumothorax, pneumomediastinum, pneumoperitoneum, investigation of choice remains a non-contrast CT. Now, management. Now, so if it is a tension pneumothorax, okay, so if it's a pneumothorax, we want to see whether the patient is a stable patient or an unstable patient. Okay, in a stable patient, we'll put an intercostal drainage tube in the 5th intercostal space mid-axillary line. But in an unstable patient, we'll have to do a needle thoracostomy. Needle thoracostomy. Okay, and where will we put it? So, in adults, we'll put it again in the mid-axillary line in the 5th intercostal space. In children, we'll put it anteriorly in the 2nd intercostal space in the mid-clavicular line. Okay. Now, some other findings of pneumothorax, again very important. So, on B mode, what do you see? You see absence of sliding pleura, and on B mode only, the most specific sign is this lung point. Okay, now what is this lung point? It is the junction where of the normal lung sliding and the abnormal pneumothorax lung not sliding. So, if you are able to see this point in an ultrasound, that is the most specific sign. And few signs on M mode. So, we know that a normal lung shows stratosphere, shows a seashore sign, but an abnormal pneumothorax lung shows a barcode sign or a stratosphere sign. Okay, we already know this. Pneumothorax is very, very important for your exam point of view. Now, good. So, let's move on to the next image. So, if in the blacked out lung, you are seeing an air fluid levels. You are seeing an air fluid levels. So, what is the diagnosis? What is the diagnosis then? Okay, good. Yes, the diagnosis is a hydropneumothorax. hydropneumothorax. That means that there is some air which has come in. So it can either be a bronchopleural fistula, or it can either be a ruptured emphysematous bulla which has leaked the air into the pleural cavity, and if there is an associated effusion, it will form an air fluid level. So you need to drain it again. So this needs to be drained. Okay, so you either put a intercostal drainage tube or a perpictal catheter drainage for drainage of this hydropneumothorax. Now coming on to this X-ray, so this is X-ray of a child, and what are we seeing here? We are seeing a very important sign. Okay, this is the Sale sign, right? This is the Sale sign, also known as the Spinnaker Sale sign. So this is known as the Spinnaker Sale sign. Spinnaker Sale sign. And where is it seen? It is seen in pneumomediastinum. Pneumomediastinum, right? And another important sign I am seeing on this X-ray itself, yes, this is the continuous diaphragm sign. This is the continuous diaphragm sign, again seen with pneumomediastinum. Now another sign of pneumomediastinum, I have labeled it here. So this is forming a V. So this is Neclarios V sign. Neclarios V sign, again seen in pneumomediastinum. Okay. So I've kept the spotters very easy, because my aim is not to give you radiology information. My aim is to make you confident about your preparation. Okay, that these are the X-rays that I know. Okay, so I know at least something. I'll be able to sit in the exam and give INI-CET confidently. Okay, because believe me when I say this, that INI-CET is all about confidence. Okay, 50% of the questions, let me tell you, 50% of the question, irrespective of how much you have studied, 50% of the questions are intelligent guesses. You have to rule out some options, and the rest of the options you have to choose the best correct option. So you need to be confident, okay, that I am sitting in this exam, I'll crack it. I'll finally able to do it. Whatever I have studied has finally boiled down to these 3 hours, and this confidence what will help you score a good rank and score high in INI-CET. So I've kept the spotters easy, and we'll finish it quickly. Now let's come on to the next image. So this is an example of silhouette sign, very important, very basic sign. Now basics ही पूछे जाते हैं INI-CET में, ठीक है, examiner basics ही पूछना चाहता है आपसे. So tell me quickly, silhouette sign says that if there is a radiopacity or a mass in the lungs and it is abutting a part of the mediastinum, so whichever part of the lung is in contact with that part of the mediastinum, the lesion is located in that lobe. So we know that the right middle lobe, RML, abuts the right heart border, the right lower lobes abuts the right hemidiaphragm. Similarly, the lingula segment, okay, now the right paratracheal stripe abuts the right upper lobe. So tell me, in this X-ray, there is a consolidation. Where is this consolidation located? So in this first image, yes, you're right, this consolidation in the right lower lobe, because we can see the right heart border clearly. The right hemidiaphragm is obscured or silhouetted. Now in this second image, we see the right heart border is not well visualized. So this lesion is in the right middle lobe, because the right middle lobe abuts the right heart border. And similarly here the right paratracheal stripe is obscured, and also looking at this X-ray, we see that the lesion or the consolidation is most likely in the right upper lobe. So this pathology is in the right upper lobe. This is the right upper lobe consolidation. Now look at these 2 X-rays. So in the first X-ray, the left heart border is obscured. Now left heart border is abutting the lingula segment. It is abutting the lingula segment of the left upper lobe. Lingula is seen in the left upper lobe of the left lung. So this is the lingula segment of the left upper lobe obscuring the left heart border. Similarly here we see that the left hemidiaphragm is obscured. So this is in the left lower lobe. So this is about silhouette sign, very very important for both for your INI-CET and NEET PG point of view as well. Now few other spotters. So this is a thick walled cavity. thick walled cavity, that's how we describe it, and we are seeing this air fluid level. So this is a lung abscess. This is a lung abscess, and again in this CT scan we see again the air fluid level. So this is again a lung abscess. Now if you see a thin walled cavity in the lung and you see these crumpled membranes on a CT scan, so this is an example of a lung hiatus. Okay. Now few infections of the lung. So which sign is seen here? Which sign is seen here? You see central consolidation and surrounding GGOs or ground glass opacities. This is the CT halo sign. CT halo sign seen in invasive pulmonary aspergillosis. Now another sign seen of a lung infection, this is the reverse halo sign. This is the reverse halo sign, also known as the bird nest sign. I'll write it here. Bird nest sign. Okay, this is again seen in a fungal infection and is more specific for mucor. Now, in an invasive pulmonary aspergillosis, whenever the inflammatory cells come, there is a crescent of air that comes in between the necrotic debris and the cavity of the cyst. This is the air crescent sign. Air crescent sign seen again in invasive pulmonary aspergillosis. Now, don't mark air crescent sign only for aspergilloma. Remember, it is also seen in invasive pulmonary aspergillosis, especially if it is healing. It tells you that it is a healing invasive aspergillosis. No, this is not COVID. Okay, so COVID can also give this appearance, but consolidation per se, consolidation alone in COVID occurs in late. Moreover, the type of GGOs that are present in COVID are in the periphery of the lung. Okay, they are peripheral and lower lobe predominant. Now, bird nesting, I agree, it can be seen in COVID. So one of the DDs can be mucor and it can be COVID also. I agree. Right, halo. Copmic, again one of the important diagnoses here is also a cryptogenic organizing pneumonia. Again, good. Right. So pneumatocoel, why is it not pneumatocoel, the earlier image? So pneumatocoels, remember, have thin walls. Pneumatocoels are not these thick walls. They don't have any air fluid levels within. So this is a lung abscess. This is not a pneumatocoel. Okay. Now let's move on to the next image. Right, so this image again shows a thin walled cavity in the left upper lobe, and we again see this ball within this cavity. So this is an aspergilloma, and what sign are we seeing here? We are seeing a monod sign. We are seeing a monod sign, right? Now tell me this diagnosis. It's a spotter. So let's say 35-year-old female comes to you with breathlessness and fatigability. Since for breathlessness we want to do a chest X-ray, you did a chest X-ray. Now tell me, what is the diagnosis here? What are you suspecting? Okay, so you see that these are dilated airways, and there is some radio opaque material in between these dilated airways. So tell me, I have already told you the buzzword here already. It is an upper lobe predominant disease, and the bronchiectasis is predominantly central. So again, tell me, TB. Yes, so for the first image, yes, aspergillomas most commonly occur with the TB, old TB cavities, right? Now for the second image, tell me, the answer here is an ABPA, ABPA or a bronchopulmonary aspergillosis. Why? Because what is this sign known as? So this is known as a finger in glove appearance, finger in glove appearance. And what exactly it is? So these dilated airways, these branching out radiopacity, are nothing but dilated airways. So that is bronchiectasis, and within that you see the mucus impaction. You see mucus plugging within these dilated bronchi, and in the given setting of fatigability, increasing breathlessness, you have to put in a possibility of ABPA. Now tell me, on CT, what is the most specific sign that you do for an ABPA confirmation? Which sign tells you that yes, it is highly suggestive of ABPA? It is a high attenuation mucus, HAM we call it. So if the attenuation is more than 60 HU on a non-contrast CT, then that is a high attenuation mucus and a very, very specific for ABPA. Good, it is an ABPA, finger in glove, right? Okay, so we move on to the next image. So now we've come to cardiovascular radiology, and I've put all the important X-ray just in one frame. So quickly we'll go and answer each one of them. So first, in this image, okay, you see a cardiomegaly, and you see a small pedicle. In addition, what else do you see? Very important finding, you see prominent vasculature of the lung. So what is the diagnosis? What is the diagnosis of this first image? Yes, the answer here is a TGA. So a narrow pedicle, cardiomegaly, prominent lung vasculature tells you it is an egg on string appearance. Egg on string appearance. Now come to the third X-ray. Come to this third X-ray. Again you are seeing a narrow pedicle, you are seeing a cardiomegaly, but the lung fields here are appearing much black than you see on the first image. So this is a Epstein anomaly. This is an Epstein anomaly, because we have read in cardiovascular system that Epstein anomaly has reduced pulmonary blood flow. Why? Because there is atrialization of ventricle. The right ventricle is small, the right atrium is large. So if the right ventricle is small, small blood goes to the lungs. That's why there is pulmonary oligemia, whereas in TGA you see pulmonary plethora. Why? Why do you see pulmonary plethora? Because from the right ventricle, if this is the heart, from the right ventricle, your aorta is coming out, and from the left ventricle, your pulmonary artery is coming out. So pulmonary artery is receiving much more blood. That's why in TGA, you see a pulmonary plethora. Now, which is the second image? Very easy image. Okay, snowman's heart. Okay, figure of 8 appearance, whatever you want to call it. So one liner, this is a TAPVC. Which particular type? Yes, it is a supracardiac TAPVC. This is a supracardiac TAPVC. Yes, and you're right, Epstein anomaly is associated with which drug? Good, you are telling me yourself. That's the power of revision. Just by seeing the image, you get to know, okay, इसके साथ ये associated था, इसके साथ ये associated था, and that's how we want to revise. Good. Epstein anomaly associated with lithium intake. Now, supracardiac TAPVC gives snowman's heart, also known as figure of 8 appearance, right? And again in this, you see pulmonary plethora. You again see pulmonary plethora. Now come to the last image, and I think most of you already know this image. This is a TOF. Why? This is a boot-shaped heart. This is a boot-shaped heart and a TOF. And the boot-shaped heart is due to which part of TOF? Tell me. The boot-shaped heart is part. So the 4 components of TOF are overriding aorta, infundibular stenosis, RVH, and ventral structural defect, VSD. Which part of these 4 results in a boot-shaped heart? Right, the answer is correct. Tell me which part of the out of the four which results in this boot-shaped heart. Yes, it is the right ventricular hypertrophy. Right ventricular hypertrophy. Okay, TOF usually presents at around 2 to 3 years of age, presents with cyanosis, and again in TOF you will see pulmonary oligemia, a blacked out lung. Okay, why? Because there is an infundibular stenosis that results in oligemia. Okay, now let's move on to the next image. So we now come to bone tumors. We are done with chest imaging and cardiovascular important heart spotters. Now I want you to quickly revise all the important bone tumors. So most of the bone tumors arise from metaphysis, so we are not going to learn them. Very few, only 2 of them are important to us that arise from epiphysis, and that are chondroblastoma, and the second one is a giant cell tumor. Now among these, it is very easy for us to understand that chondroblastoma occurs in and GCT occurs in adults. That is, after skeletal maturity there is a GCT in epiphysis, and before skeletal maturity there is a chondroblastoma in epiphysis. So again our job is done, our job is easy. Now diaphysis tumors are again limited in number. So what are the diaphysis tumors? So remember, osteoid osteoma, fibrous dysplasia, Ewing's sarcoma, METs and multiple myeloma, adamantinoma, lymphoma and eosinophilic granuloma. Right, and amongst these, osteoid osteoma very important, FD important, Ewing's very important, and adamantinoma very important. Now for adamantinoma, we'll come and see spotters of each and every one of these, because bone tumors is one topic that is asked in your radiology, ortho, and one question from bone tumor you'll definitely get in your exams. Now let's come to the first image. So this is a 15-year-old boy, so a child, we see a lesion in the epiphysis. The physeal plate has not yet fused, it is open. So answer direct here is a diagnosis is chondroblastoma. Okay, age why? Because it is a child and our location is epiphysis. Okay, straightforward, should not be wrong for anybody. Now also remember that it can be present in apophysis, that are tuberosities and trochanters. एपोफाइसिस का ट्यूमर भी कॉन्ड्रोब्लास्टोमा ही होता है चिल्ड्रन में मोस्ट कॉमनली. नो, इट इज नॉट ईविंग सार्कोमा, नॉट एट ऑल. ठीक है, so somebody has answered it as GCT. No, GCT occurs in old. So I told you already in the previous slide that GCT occurs in adults. So you will see physeal closure. You see that the growth plate in GCT will be closed. Here it is open. That means it is a skeletally immature child. So answer here will be a chondroblastoma. Now compared to the previous image, see this image that the physis here is closed, and again we see a lesion in the epiphyseal location reaching up to the metaphysis, and it is reaching till the articular surface. See here also in the distal end of radius you see a lesion reaching till the articular surface, just till the joint, and it is in the epiphysis. The second important point, it is in a skeletally mature child. So yes, I think most of you got this answer correct, GCT. So age is adult and location is epiphysis. Now appearance is not so important, so somebody says soap bubble appearance, but you know, whenever there are multiple septations within a lytic lesions, so that will give a soap bubble appearance. So in ABC, in GCT, in brown tumors, soap bubble appearance does not really help us. What helps us is age and location. Okay, these two are the most important factors, most important pointers for a bone tumor diagnosis. Good, everybody has answered this. This is a GCT. Now tell me this diagnosis, very easy. So This is a Shepherd crook deformity seen in fibrous dysplasia. Recently asked in the form of a syndrome. So polyostotic fibrous dysplasia with precocious puberty with cafe au lait spot is McCune-Albright syndrome, right? And this is also a case of craniofacial fibrous dysplasia. This is a craniofacial. So fibrous dysplasia very commonly involves the facial skeleton. Okay, and which appearance is this? This is the ground glass appearance. So two syndromes we have read, McCune-Albright syndrome, and second one is a Maza-Brod syndrome. It is associated with polyostotic fibrous dysplasia and also which second part is there in Maza-Brod? Yes, these are soft tissue myxomas. They are soft tissue myxomas. Right. Let's come to the other next image. So typically this is an adult, and you see that there is a lesion in the diaphysis. And diaphysis, a very specific bone, affects this kind of tumor. This tumor affects a very specific kind of bone. This is an adamantinoma. So this is an adamantinoma. Age is an adult or a young adult, and the location is diaphysis. Which typical bone? A specific bone is affected here. It is the tibia, very specific to tibia this tumor is. Now similar type of tumor occurs in the jaw, having almost the same histology. This is the ameloblastoma. Remember, adamantinomatous histology in a jaw tumor is an ameloblastoma. Now again a tumor we are seeing in the distal radius, but look at here carefully that the epiphysis is separately seen. This tumor is mainly involving the metaphysis, and again a lytic lesion, expansile lesion giving a soap bubble appearance. So, but this is a child. Why do we say it is a child? Because the physis has not yet closed. We are seeing the growth plate separately. So this is a child. This is a child right here, and the location is metaphysis. It is eccentric, having multiple septations, and the answer here is a aneurysmal bone cyst. ठीक है, ABC वर्सेस GCT बड़ा आसान है. मेटाफाइसिस में होगा चाइल्ड में होगा ABC, एपीफाइसिस में होगा एडल्ट में होगा GCT. ठीक है, वेरी इजी फॉर अस टू अंडरस्टैंड. Now let's see the next image. So again this is a lesion occurring in a child in the metaphysis, having a unilocular simple बड़ा सा cyst लग रहा है, उसमें एक fractured fragment दिख रहा है. Again a very simple diagnosis for us. This is a simple bone cyst. Typical location is at the upper humerus. ठीक है, very typical location this tumor has, and we all know this is the fallen fragment sign. Fallen fragment sign. ठीक है, another sign that is seen in SBC, hinged door sign. Okay, hinged door sign. If this fracture fragment is not fallen into the tumor but it is attached to the cortex, then it is known as a hinged door sign. Right? Now let's come to the other tumor. So whenever hand X-ray is given to us and we see a hand tumor, so the bell should ring in our mind that it is an enchondroma. ठीक है, हाथ में ट्यूमर होगा, स्मॉल हैंड्स एंड फीट. विच ट्यूमर अफेक्ट्स द स्मॉल हैंड्स एंड फीट? इट्स द एनकॉन्ड्रोमा, राइट? एंड मल्टीपल एनकॉन्ड्रोमास. सी दिस सेकंड इमेज, you see that there are multiple bone tumors here. This is one bone tumor, this is one bone tumor, again a tumor of the small hand, so it's an enchondroma, multiple enchondromas. But these soft tissue hemangiomas, you are seeing these phleboliths. These are nothing but phleboliths, and these are multiple enchondromas. So tell me, which syndrome am I talking about? Which syndrome am I talking about? Multiple enchondromas. Okay, multiple enchondromas isolated is all ears, but if it's associated with soft tissue hemangiomas, so it is a Maffucci syndrome. Maffucci syndrome. ठीक है, बोन ट्यूमर अच्छे से पढ़ना है हमें. बोन ट्यूमर्स पे पक्का एक क्वेश्चन आता है, एंड बोन ट्यूमर्स आर वेरी इजी फॉर अस टू अंडरस्टैंड. 2-3 बार पढ़ लोगे बोन ट्यूमर्स को, यू विल एबल टू डू ऑल द क्वेश्चंस फ्रॉम बोन ट्यूमर्स. ऑर्थो रेडियो कंबाइंड पढ़ना है, इंटीग्रेटेड फॉर्म में पढ़ना है. सो जब भी ऑर्थो से एक बार बोन ट्यूमर्स पढ़ रहे हो, एक बार मेरी क्लास खोल के देख लो कि सर ने कैसे क्विक चीज़ें बताई, कौन सी चीज़ क्या है. ठीक है, Maffucci syndrome, good. Hemangiomas plus multiple enchondromas. Let's move on to the next question. So it is a child coming to you in the emergency with pain, fever and redness of limb. Okay, you're suspecting an infection, but you do an X-ray and you see this kind of picture. So this is an multilamellated periosteal reaction, onion peel type of periosteal reaction. And what do we see here? What is the diagnosis? This is an Ewing's sarcoma. So age is usually less than 10 years. Okay, location, it affects the diaphysis. Now if it's affecting the diaphysis, then those are the long bones, diaphysis of long bones. But remember, Ewing sarcoma also affects the flat bones, and for flat bones, remember, it is the most common malignant bone tumor of flat bones in children. Okay, so pelvis, scapula, ribs, if you are seeing a malignant bone tumor, most likely it is a small blue round cell tumors, and one of the small blue round cell tumor is an Ewing sarcoma. So कौन सी family of tumors है? This comes under a, which is the big family. The big family of tumor is the small blue round cell tumors, Ewing sarcoma. Okay, ठीक है. So periosteal reaction we have already read. It is an onion peel type of periosteal reaction. Now let's come to another spotter. So it is again a child. So remember, this type of tumor can either occur in young adults or it occurs in child. The history is that of a night pain relieved by aspirin, very specific history, and you see this type of X-ray. So there is small lytic lesion with exuberant perilesional sclerosis. So again you see on a CT, this is the lesion and then there is exuberant sclerosis. The answer here is an osteoid osteoma. Okay, age is either a child or young adult. Location, typically I told you in the starting itself, it is the diaphysis, and clinical features are night pains relieved by aspirin. Now what is the treatment of choice? This bone tumor has this lytic area, this is the nidus. So you have to ablate this nidus by radio frequency ablation. Okay, so RFA remains the treatment of choice for osteoid osteoma. Good. Now let's move on to the next bone tumor. So this is a tumor consisting predominantly of bone having a medullary continuity. Okay, there is medullary continuity with the main parent bone and also the cortical continuity. So this is an osteochondroma, again a very easy spotter for us. And remember, osteochondroma grows away from the joint. Okay, if this is the joint line, this tumor is growing away from the joint line, right? And osteochondroma has this cartilaginous gap at the top. Now again a previously asked question in AIIMS, what are the features of malignant transformation in an osteochondroma or an exostosis? So we know that cartilage cap thickness, if the cartilage cap thickness is more than 20 mm, some says more than 15 mm, then it is suggestive of malignancy. or if this tumor keeps on growing even after skeletal maturity, okay, then it also means that there is a malignant transformation that has occurred. Now, multiple osteochondromas, what is this syndrome? This is diaphyseal eclasia. Multiple enchondromas is diaphyseal eclasia. Right? Now, again a very important tumor, very easy tumor. So, a malignant tumor occurring in metaphysis having this sunburst periosteal reaction, right? The answer here is in, tell me the answer. The answer here is an osteosarcoma. Osteosarcoma. Age क्या होती है इसकी? Between 10 to 20 years. So, Ewing sarcomas less than 10 years most common, osteosarcomas around 10 to 20 years. Location metaphysis, matrix, osteoid matrix, bones, long bones metaphysis, and periosteal reaction, sunburst type of periosteal reaction. Now, one important sign also seen in periosteal reaction, Codman's triangle that we see in osteosarcoma. However, Codman's triangle, remember, is not specific for osteosarcoma. Codman's triangle occur in any aggressive bony lesion. So, even osteomyelitis can show you raised periosteum giving this Codman's triangle sort of thing. So, remember, osteoid matrix having a metaphysis, children, sunburst periosteal reaction, osteosarcoma. Now, just quickly tell me a type of osteosarcoma that is predominantly lytic. Okay, type of osteosarcoma which is predominantly lytic and has air fluid levels on MRI. Yes, that is a telangiectatic osteosarcoma. The telangiectatic osteosarcoma can be purely lytic also. Now, again a spotter. So, if this is an adult, I tell you this is an adult aged 50 years of age, and you see these ring and arc type of calcification, these ring and arc type of calcifications. So, these are specific for chondrosarcoma. Okay, remember, chondrosarcoma is the most common malignant bone tumor. Malignant bone tumor of adults in flat bones. And most common tumor, I mean primary tumor, adults, flat bones, chondrosarcoma is the most common. Okay, so location again will be metaphysis, age will be adults, matrix is a chondroid matrix. So, these see ring and arc type of calcification. So, what type of calcification we see? Ring and arc. Okay, bones can either be long bones or it can be flat bones. No specific periosteal reaction occurs here. Right, radio-resistant tumors, chondrosarcomas. Now, we move on to some arthritis. Okay, name this sign. Okay, so let's say this is a 27-year-old male having low backache, inflammatory type of low backache. So, whenever he wakes up from the bed in the morning, he feels very stiff back. Okay, he's not able to get up, there is very stiffness in the back. Okay, and you do an X-ray and you see this spine. So, this is a dagger sign because of calcification or ossification of the interspinous ligament, and also you see that the bilateral SI joints are fused. So, this is an ankylosing spondylitis. What is the age? Usually affects the young males. It affects the young males predominantly. Joints involved are the SI joint and the spine. And what are the findings that you see? You see, first, early findings starts in the SI joint. So, early findings are sacroiliitis. Remember, for sacroiliitis, we have to do an MRI, in which we see bone marrow edema. Now, which sequence of MRI picks up bone marrow edema? It is the stir sequence. Right, this is the dagger sign. Stir picks up the bone marrow edema, and later on, when the inflammation slowly progresses, you see changes in the spine in the form of syndesmophytes. Okay, you see ossification of these spinous ligaments, so tram track appearance, tram track sign, dagger sign are all spines के signs of ankylosing spondylitis. Now again a mimicker of this spinal calcification. So if you see calcifications along the anterior longitudinal ligament, anterior to the spine you see calcifications, and this is an elderly patient. And these calcifications are big calcifications appearing like a candle wax, a flowing candle wax type of calcifications. So we are dealing with DISH, diffuse idiopathic skeletal hyperostosis. So H is hyperostosis. ठीक है, ज़्यादा calcification हो रहा है along the anterior longitudinal ligament. So remember DISH. ठीक है, good, everybody has answered it correctly. ठीक है, we'll quickly finish up. ठीक है. Now again a type of arthritis we see, again an inflammatory type of arthritis. So a 35-year-old female comes to you with swollen small joints of hands. ठीक है, hands, and wrist also has pain, and there is again morning stiffness. The pain relieves on activity. His inflammatory markers ESR, CRP are elevated. So you are thinking of an inflammatory arthritis affecting the hands, and you see that the DIP, are spared, and the predominant joints involved are the proximal interphalangeal joint and the wrist joints. Okay, so if it is an inflammatory type of arthritis affecting the young female and the small joints are involved, so we have to think of the prototype inflammatory arthritis, that is the rheumatoid arthritis. In comparison, if on an X-ray you see this telescoping of one bone into the other, you see this exuberant bony proliferation, okay, and you see this destruction of bones, and the DIP is also involved. Okay? And also in the question, if it's given that the patient has some skin lesions as well and backache as well, so it is spondyloarthropathy with skin lesions, and the prototype for that is a psoriatic arthritis. Okay, so joints involved can be hand joints, and in hand joints remember DIP is involved along with PIP and the wrist joint, and the spine can also be involved in the form of spondyloarthritis. What are the important signs? So you see pencil-in cup deformity, you see telescoping of one bone into other. Okay, and the hallmark, remember the hallmark of psoriatic arthritis is this periostitis. So this can be asked in a one-liner also, or on a multiple option correct type question also, that the hallmark of arthritis on X-ray is a periostitis. Okay, that's why you get these bony proliferations. Okay, these are characteristic of psoriatic arthritis. Now let's move on to the next question. So you have a young male who comes to you with acute monoarthritis. Okay, there was a history of binge drinking of beer the last night, and the next day in the morning he develops severe pain and inflammation in his great toe or in the small joints of his foot. And if you do an X-ray, you see these big erosions. You see these big erosions along the margins of the joint, and along with that you see these soft tissue deposits. So this is an acute monoarthritis, and the prototype that we are talking about is the gout. Okay. Now what are these big erosions known as? These are rat bite erosions. And remember, in gout the joint space is maintained. Okay, very important factor, joint space is maintained in gout. In all the other inflammatory arthritis, we have read that the synovium is involved, and so if the synovium is involved, there will be joint space narrowing. But in gout, it is due to monosodium crystal deposition, the joint space is maintained in gout. Now we have read in CT any important investigation which can help us in seeing this gouty deposits. So what are these deposits? First of all, These are monosodium urate crystals, MSU crystals, needle shaped negatively bifringent on polarized microscopy, and you can see these monosodium crystal deposition using a type of CT known as dual energy CT. Okay, DECT based upon material decomposition lets you see these specific MSU deposits within the joint, right? So let's move on to the next question. Now, in a gout, I want you to name another entity related to gout, that is pseudo gout, that is calcium pyrophosphate deposition disease, pseudo gout. And what type of crystals do you see there? So you see positively bifringent and rhomboid shaped crystals on polarized microscopy in CPPD. And CPPD, again, very important for pointer, that there is calcification, chondrocalcinosis. So I am writing it here, pseudo gout, hallmark of pseudo gout is chondrocalcinosis. And where do you see chondrocalcinosis? Medial meniscal calcification. You can see TFCC, trifibro cartilage calcification of the wrist. So TFCC calcifications, meniscal calcifications, chondrocalcinosis seen in pseudo gout. Now let's move on to this next X-ray. So a very bad looking X-ray, I can say. There is a lot of destruction, disorganization, sclerosis and dislocation happening here. But if you ask the history, patient has mild pain in the foot, patient is a diabetic or has syringomyelia, has peripheral neuropathy, but there is a very bad destruction of the joints that you are seeing here. So there is a clinico-radiological discordance. And what is the diagnosis here? It is a neuropathic joint. Okay? So you see extensive destruction, disorganization, displacement, debris, joint distension. So I am talking about the 6 Ds that are associated with neuropathic joint, also known as a Charcot's joint. Okay? Now let's move on to the next image. So again, nutritional deficiency, metabolic bone diseases are very important topics for your entrance exam, specifically INI-CET. So whenever you see a wrist X-ray, okay, first thing that comes to our mind is rickets, right? And for 2-year-old child with weakness in short stature, and you're given a hand X-ray, ठीक है, short stature है but hand X-ray दिया हुआ है, तो ठीक है, rickets ही पूछना चाह रहा है examiner. And what do we see? Obviously, we can see it very well on this image. So there is metaphyseal widening, there is cupping of metaphysis, there is spaying and fraying. Okay, so these are typical hallmarks of rickets. Okay, these are typical hallmarks of rickets. Now, in comparison to this, if you see again a young child with joint pains, okay, there is joint pains, bone pains, and there is bleeding disorders. Okay, gum bleeding, then you're suspecting a scurvy. And in scurvy, we know that there is this sclerosis that happens, white line of Frankel. Unlike scurvy, in which there was this fraying that was happening at the metaphysis. So in scurvy, there is sclerosis. And another thing you'll see that the epiphysis is sclerosed. So ring epiphysis known as Wimberger's sign. So Wimberger's sign is the ring epiphysis. This is the white line of Frankel. Okay. Also other signs that you are seeing, not so important, Trummerfield zones, Trummerfield's radiolucent zone, Pelkin spur, but only see the ring epiphysis and the white line of Frankel to differentiate between scurvy and rickets, because knee X-ray can also be given to you in the exam and it can show changes of rickets, not necessarily scurvy. So you need to differentiate between the two, right? Wimberger's ring sign, widening of epiphysis and metaphysis and rickets, good, okay, easy questions. Now, okay, if I give you a 50-year-old postmenopausal female having low back ache and you do this X-ray, you see this compression fractures, the bone, the vertebral body height has reduced. Okay, these are compression fractures. Okay, this is a fish mouth appearance or a codfish appearance of vertebra, and you see that the bone mineral density is homogeneously reduced. It is a black appearing spine. Okay, इतना काला नहीं दिखता है spine में. So this is an osteopenia that has happened of fish vertebra. There is reduced bone mineral density, and which is the investigation that we do for osteoporosis. It is the DEXA scan, right? Dual energy X-ray absorptiometry. And what do we see on DEXA? We do T scoring. Okay, the bone mineral density of this patient is compared with that of a healthy individual, and the T score is calculated, and the T score less than 2.5. If the T score is less than 2.5, then that is a hallmark of osteoporosis. So osteoporosis is defined by T score less than 2.5. If the T score is between -1 to -2.5, then tell me what's the diagnosis? Between -1 to -2.5 is osteopenia. Okay, this is the image of the DEXA that we get. Okay, so DEXA measures the bone mineral density in the lumbar spine and the neck of femur, and it calculates your T score. Okay, young adult T score. So in T score, the bone mineral densities, first of all, this can be asked, it is matched with a young adult. Okay, not age match. Okay, so let's say this is a 35-year-old female. You don't match the bone mineral density with the corresponding 35-year-old female. You match it with a young adult and calculate the T scores, and the T score less than -2.5 is suggestive of osteoporosis. Now let's see some brain spotters, some head and neck and brain spotter. So this is previous year question. This was actually asked during my INI-CET. So a young child experiences, the mother of a young child experiences a slow growing palpable swelling on the scalp. Okay, slow growing palpable swelling on the scalp. There was a history of trauma to the head around 2 years back, and since the last 1 year, the mother has been seeing this slow growing swelling on the scalp, and you get to do an X-ray, and what do you see? You see this large defect in the calvaria. You see this large bony defect in the calvaria. This is nothing but a growing skull fracture. This is a growing skull fracture. Why does it happen? The pathology behind this is a leptomeningeal cyst. Leptomeningeal cyst. Okay, good. Growing skull fracture. Okay, no, this is not LCH. Why this is not LCH? LCH, remember, has smaller lesions and they have beveled edges. Now, what is a beveled edge in LCH? So, if this can be this is a punch out lesion, but in beveled lesions, you see two edges. Okay, so one is slightly inferior and another edge is slightly outside. So this is a beveled edge that you see in LCH. Remember, LCH के इतने बड़े lesions नहीं होते. And the typical history that I gave you was a slow growing palpable swelling on the scalp. There was a history of trauma 2 years ago. So remember, this is a growing skull fracture or a leptomeningeal cyst. Why does it occur? Because there is an associated dural tear. So whenever the trauma happened, there was a tear in the dura. So if this is the skull, if these are the meninges, so there was a small dural tear from which the CSF started escaping, and slowly a cyst, leptomeningeal cyst, started forming and growing. So whenever this cyst starts growing, since it's a child, the skull fracture also expands. So it is actually a growing skull fracture is a misnomer. The underlying pathophysiology is a dural tear resulting in a leptomeningeal cyst. Okay, now let's move on to the next. So head trauma, very important. We'll quickly finish it because I think most of you know how to differentiate between an EDH and an FDH. इतनी बार पूछ चुका है तो अब तो रट ही गया. So which one crosses the suture? Crossing a suture is seen by FDH. EDH does not cross the suture because at the suture the periosteum fuses with the bone, right? Now which one crosses the midline? So remember, EDH crosses the midline. Okay, we'll write it quickly. So EDH crosses midline. Remember, you can see it in the image also that EDH is crossing the midline, but FDH cannot cross the midline. It dips along the falx cerebri. So FDH does not cross midline. ठीक है, but FDH can cross sutures. EDH cannot cross sutures. ठीक है, and EDH is due to high velocity trauma, arterial bleed, most common bleed, middle meningeal artery, shape biconvex. I have told the shape at the last because shape is the least important parameter. FDH, venous bleed, trivial trauma, elderly, crosses suture, cannot cross midline, most common artery, emissary veins of the calvaria. ठीक है, क्विक कैप्सूल बस सुन लो, लिखने की कोई ज़रूरत नहीं है. एवरीबडी नोज हाउ टू डिफरेंशिएट बिटवीन EDH एंड FDH. ठीक है, EDH कैन क्रॉस मिडलाइन. गुड. EDH लूसिड इंटरवल अगेन यस. अगर लूसिड इंटरवल दे रखा है क्वेश्चन में तो वी आर टॉकिंग अबाउट EDH. नाउ अगर वर्स्ट हेडेक ऑफ लाइफ दे रखा है, ट्रॉमा की सेटिंग है, वर्स्ट हेडेक ऑफ लाइफ दे रखा है, देन SAH होगा. ठीक है, थंडर क्लैप हेडेक दे रखा है, SAH होगा. SAH के लिए इन्वेस्टिगेशन ऑफ चॉइस, रिमेंबर फॉर ऑल हेड ट्रॉमा इन्वेस्टिगेशन ऑफ चॉइस इज अ नॉन कंट्रास्ट CT. बट अगर क्वेश्चन में दे रखा है कि SAH है, NCCT हो गया, उस पर SAH चल गया पता, देयर इज नो हिस्ट्री ऑफ ट्रॉमा, इट इज स्पॉन्टेनियस SAH, तब नेक्स्ट इन्वेस्टिगेशन क्या होगी? टू सी द कॉज ऑफ SAH, तब हमें CT एंजियोग्राफी करनी होगी. ठीक है, whenever we want to ascertain a cause of a non-traumatic SAH, a proven SAH on NCCT, then we have to do a CT angiography. ठीक है. Now let's move on to the next image. So again a spotter asked previously in INI-CET. ठीक है, a lumbar swelling. ठीक है, tuft of hair in the midline, but a cranial ultrasound is given. So this is the Lemon sign. ठीक है, Lemon sign. You see pinching of calvaria, anterior calvaria, frontal calvaria is pinched like a lemon. And why does it happen? It happens in spinal dysraphism because of herniation of posterior fossa contents downward. So anterior fontanelle compresses. Okay, so there is a Chiari malformation in which the posterior fossa contents have herniated downwards, and there is an associated meningomyelocele or a lumbar spinal dysraphism. So seen, you get a Lemon sign there. Now similarly, if there is wrapping of the cerebellum, if there is wrapping of the cerebellum around the pons, this is the pons, then this is the banana sign. Banana sign again seen with Chiari malformations because of posterior fossa herniation contents. Now let's see stroke imaging. ठीक है, so stroke के लिए first of all stroke is the clinical diagnosis, it's not an imaging diagnosis. First of all, sudden onset neurological deficit due to a vascular cause is stroke, right? Now to see the extent of stroke, now in a stroke if suspected, if there is a sudden onset neurological deficit, that is a stroke, then we do an NCCT. Next step is an NCCT. And why do we do an NCCT? Because we want to differentiate between a hemorrhagic stroke and a ischemic stroke. ठीक है, you want to differentiate between a hemorrhagic stroke and an ischemic stroke. And before doing an NCCT, just to rule out one important mimic of stroke, only investigation in a suspected case of stroke before doing an NCCT is a blood glucose. ठीक है, only blood glucose you have to do. But ठीक है, अगर फोकल न्यूरोलॉजिकल डेफिसिट है, सडन एक्यूट ऑनसेट है, NCCT इज द नेक्स्ट इन्वेस्टिगेशन आफ्टर अ रैंडम ब्लड ग्लूकोज सैंपल. एंड इन अ स्ट्रोक, डिपेंडिंग अपॉन द एज ऑफ स्ट्रोक, सो इफ इट इज अ हाइपर एक्यूट स्ट्रोक, यू सी दिस dense MCA sign. So dense MCA sign seen in hyper acute stroke. You can actually see the clot. What does dense MCA tell you? That it is actually a clot within the middle cerebral artery that we can see on an NCCT. but let's say around 4 to 6 hours have passed. So hyperacute stroke is less than 6 hours. So after let's say some time has elapsed, 4 to 6 hours have passed, you can see changes of stroke. These are early ischemic changes. So what are the early ischemic changes of stroke that you see on non-contrast CT? So I'll just tell you the name verbally. You have already noted this. So disappearing basal ganglia sign, insular ribbon sign, loss of gray-white matter differentiation in the cerebral cortex. Okay, all these are early ischemic changes of a non-contrast CT. Okay, so one thing that you have to remember is a loss of gray matter, white matter differentiation. एंड इसी के सारे साइंस होते हैं, ठीक है, जो हम पढ़ते हैं, डिसअपियरिंग बेसल गैंग्लिया साइन, ठीक है, इंसुलर रिबन साइन, ऑल आर अर्ली इस्कीमिक चेंजेस ऑफ एनसीसीटी. नाउ बेस्ड अपॉन एनसीसीटी, टेल मी वन इंपॉर्टेंट स्कोर that is used to decide the therapy. So patient has come on within 6 hours, okay, he is in window period for mechanical thrombectomy and you have done an NCCT. Okay, which important score are you looking at to decide whether mechanical thrombectomy can be done or not? Okay, one important score, tell me. Yes, this is the aspect score. Okay, aspect scores for anterior circulation, MC infarct, Alberta stroke program, early CT score. Okay, so total score is still 10 and we sequentially subtract the areas that are involved. So it can be asked to you as an image based question that calculate the aspect score of this patient. So you see 6 regions. So caudate nucleus, lentiform nucleus, 1 score for each, internal capsule 1 score each, insular ribbon, okay, insular cortex 1 point each, then 3 areas in the cerebral cortex at the level of basal ganglia, anteriorly M1, M2, M3, then above the level of basal ganglia, suprabasal, M4, M5 and M6. So let's say these seven areas are involved. Okay, we have involvement of the caudate nucleus, lentiform, internal capsule, insular ribbon and the cortex at the level of basal ganglia. So that will be 10 minus 7, so it is a 3. Aspects 3 is a very bad aspect. Remember, if aspects is less than 7, that means that your mechanical thrombectomy will do more harm than good. Okay, it will lead to hemorrhagic infarction. So aspects less than 7, mechanical thrombectomy is contraindicated. Okay? Now, let's come to the GIT radiology now and we'll quickly finish our class. It's already quite a lot of time. So important diagnosis, very easy to understand, very commonly asked, air under the diaphragm, mostly given as a surgical question, not a radiological question. So let's say a 35-year-old female comes to you in the emergency with acute abdominal pain, there is guarding and rigidity, and you do an X-ray and you see air under the diaphragm. This is a pneumoperitoneum and you have to open the patient. Okay, so this requires an exploratory laparotomy. This requires a laparotomy. Okay. Now a mimicker of pneumoperitoneum is this Chilaiditi syndrome. This is a Chilaiditi syndrome. Basically what happens in Chilaiditi syndrome, the hepatic flexure gets interposed between the right hemidiaphragm and the liver surface. So you see these Hofstray. These are nothing but colon which has interposed between the right hemidiaphragm and the liver. Now, whenever we talk about pneumoperitoneum, if you want to confirm pneumoperitoneum, although it's a clinical diagnosis, take a patient has come to you in emergency with guarding rigidity, you do an X-ray, you see pneumoperitoneum, then further no investigation is required, you have to directly take the patient to laparotomy. But if you are confused, okay, if let's say Chilaiditi syndrome lag raha hai ya air under diaphragm nahi lag rahi hai, but you are suspecting clinically it's a pneumoperitoneum, then NCCT is the investigation of choice. I told you earlier, जब भी हमें air देखनी होती है तो हम NCCT करते हैं. Okay. Now there are some named signs. Quickly सब एक एक बता दो. So if there is air surrounding both the sides of bowel, ठीक है, if there is air if there is air surrounding both the sides of the bowel and the bowel wall is very well seen. So what is this sign? This is the Wriggler's sign. Now tell me the second sign, a massive pneumoperitoneum. The abdomen is looking in the shape of a soccer football, American football. So football sign. Football sign. ठीक है, next sign tell me. Next sign tell me, air under the central dome of diaphragm appearing like a dome. ठीक है, this is the cupola sign. Cupola sign is air beneath the central tendon of the diaphragm. Pneumonitis. Now tell me this sign. These are ligamentous sign associated with pneumoperitoneum. So if the falciform ligament is well outlined, so this becomes the falciform ligament sign. If the lateral umbilical ligaments are well outlined, then this becomes the inverted V sign. Okay? And if there is air entrapped between the bowel wall in the shape of a triangle, then this is a triangle sign or a telltale sign. This is a triangle sign or a telltale sign. Okay, so these are the important signs associated with pneumoperitoneum. Okay, Wriggler's, it's a Wriggler's sign that's there. Okay. Now, an important question, a previous question for INI-CET from INI-CET, it was actually asked during my INI-CET. Now, if you see a thin, lean patient, okay, thin, lean patient, history में देखा होगा, there is anorexia, maybe the patient has eating disorder like anorexia nervosa, and there is an obstruction, small bowel obstruction, and on X-ray you see that the stomach is distended. The stomach is distended and you are suspecting a vascular compression. So one of the syndromes is an SMA syndrome. So one of a syndrome is a superior mesenteric artery syndrome, in which the third part of the duodenum gets compressed between the superior mesenteric artery and the aorta. Okay, the third part of the duodenum gets compressed between the superior mesenteric artery and the aorta. And normally this angle, normal value of this aortomesenteric angle, that is the angle formed between the superior mesenteric artery and the aorta, the normal value is around 25 to 65 degrees. Now, till what level is it narrowed that we call it SMA syndrome? So first of all, for SMA syndrome to happen, patient should be clinically symptomatic. Okay, clinically symptomatic patient, and if this angle value is between 6 degrees to 22 degrees, between 6 to 22 degrees, then that is suggestive of an SMA syndrome. So here in this case, the angle is around 15 degrees and the patient was symptomatic. So this is a case of SMA syndrome. Now, if the duodenum is not compressed, but the left renal vein is compressed, the left renal vein is compressed between the SMA and the aorta. So I'll write it here. If left renal vein, if the left renal vein is compressed, किसके बीच में? Between SMA and aorta, then we call it nutcracker syndrome. So nutcracker syndrome is not compression of duodenum, it is compression of the left renal vein. This is the nutcracker syndrome. Okay. Now we move on to the next image. So we are doing GIT. So this is a 2-year-old male, 2-year-old child comes to you with a very severe abdomen pain. So 2-year-old child does not tell you there is pain. The child is crying continuously, inconsolable crying, and you are given in the question maybe rectal bleeds or a typical red currant jelly stools. Now red currant jelly stools tells us that yes, the examiner is talking about intussusception, and which are the two important signs that we see on intussusception. So you can call it a target appearance or a donut sign. So this can either be a target appearance, a target sign, or a donut sign, or on a longitudinal section. If you cut it like this, then you get a pseudo kidney sign. Okay, pseudo kidney sign, and which is the gold standard for diagnosing intussusception. It is the barium enema. ठीक है, barium enema में you see this claw sign. ठीक है, claw sign is seen in barium enema. And why is the gold standard barium enema? Because you can also reduce the intussusception. You can reduce the intussusception by doing this hydrostatic reduction or a pneumatic reduction. Mostly आजकल के time में pneumatic reduction is most commonly done, but hydrostatic reduction is also practiced at some centers. Now let's come to another very important liver lesion, that is the hydatid cyst, and we want to remember the WHO classification. The WHO classification. ठीक है, so remember that CE1 is a unilocular clear cyst. ठीक है, these unilocular clear cyst if develops multiple septae, that is multiple daughter cysts, this is CE2, and these two are active stages. These two are active stage. If this membrane has detached, then what is this sign known as? A water lily sign. ठीक है, this is a transition phase. This is a transition phase, and the CE2 sign, in which there was multiple septae, what was it called? Honeycomb appearance. ठीक है, remember that among the active stage, it is CE1 type clear stage in which we can do pair. Pair is percutaneous puncture. There is puncture, aspiration, instillation of scoliocidal agent. What is the most common scoliocidal agent that we use? Which is the most common scoliocidal agent that we used in CE1 type of clear hydatid cyst for pair? It is absolute alcohol, 95% absolute alcohol, or even hypertonic saline can be used, and then we re-aspirate that scoliocidal agent. So that is pair for you, done in CE1 type of lesions. Now as the cyst progresses, so there is solidification of this cyst, and finally this calcified cyst, this is the inactive stage. This is finally the inactive stage of this hydatid cyst. ठीक है? Yes, one another classification apart from WHO is the Garby classification, but now WHO is the most commonly used classification, and remember WHO classification is based upon CT, MRI or ultrasound. It is based upon ultrasound. It is based upon ultrasound. Now few spotters of the genitourinary system. So first of all, tell me which investigation is this? You are seeing this catheter going up to the renal pelvis and injecting contrast. So this is RGUP. ठीक है, don't answer it as IVP please. ठीक है, IVP में पहली बात बायलेटरल किडनीज होंगी आपके पैसिफाई, बायलेटरल PCS पैसिफाई होंगे, एक ही साइड का पैसिफाई हो रहा है. तो दिस इज नॉट IVP. MCU भी नहीं है, MCU में रिफ्लेक्स भी नहीं बोल सकते. क्यों? क्योंकि ब्लैडर में कंट्रास्ट नहीं है, तो मतलब MCU नहीं है. ठीक है, तो इट इज एन RGUP. यू कैन ऑल्सो सी द कैथेटर. नाउ विच इज द सेकेंड इमेजिंग, सेकेंड इन्वेस्टिगेशन दैट वी आर सीइंग? यस, दिस इज एन MCU, मिक्चुरेटिंग सिस्टोयूरेथ्रोग्राम. ठीक है, डन फॉर posterior urethral pathologies mainly. Posterior urethral valve के लिए it is the investigation of choice, and also for VUR, vesico-ureteric reflux. Now this is how a posterior urethral valve appears, the dilated posterior urethra. Also you can see it on the antenatal ultrasound. Dilated posterior urethra gives a keyhole appearance. keyhole sign seen in posterior urethral valve. ठीक है, this is again an image showing you bilateral vesico-ureteric reflux. Bilateral vesico-ureteric reflux. Actually, I have cropped the image. You can also see the urethra here. So if the urethra is seen, that means the patient is micturating and there is bilateral associated vesico-ureteric reflux. Now, let's come to few important similar looking images. बहुत confusion होता है. So पहली image क्या है? पहली image में, ठीक है, पहली image क्या है? पहली image में you see that there is no contrast in the ureters or the bladder or the urethra. So this is a plain X-ray. This is a plain X-ray and you are seeing this radiopacity outlining the pelvic ileal system in the shape of pelvic ileal system. So this is the Staghorn. This is the Staghorn calculus. Whereas in the second image you are seeing the contrast in the ureters and the bladder, but there is no opacification of urethra. Okay, so this is an IVP and you see there is narrowing at the level of right pelvic-ureteric junction and there is associated right hydronephrosis. So this is a PUJ obstruction. Now in this third image you can see the urethra, matlab the patient is micturating. So this is a MCU, micturating cystourethrogram, and what is it showing? It is showing you vesico-ureteric reflux. ठीक है, तो पुट्टी किडनी किसी ने पहले ही बोल दिया, पुट्टी किडनी पर हम अभी आए नहीं है, आप मोडालिटीज बताओ पहले. ठीक है, सो दिस वाज IVP, दिस वाज MCU. Now again tell me what is the diagnosis here. You are not seeing the ureters. Tell me the diagnosis of this fourth image. In the comment section, tell me the diagnosis of this fourth image. ठीक है, you are seeing radiopacity outlining the pelvic ileal system. ठीक है, cortical outline नहीं है, ये PCS जैसा लग रहा है. ठीक है, so this is bilateral Staghorn. This is bilateral Staghorn calculus. Whereas compare it to the fifth image, the calcifications is in the shape of the kidney. पूरी kidney calcify हो गई. ठीक है, this is the putty kidney that we see in TB. That we see in TB. And finally, if you see calcifications along the renal pyramids, so this is how your medullary nephrocalcinosis occurs. Medullary nephrocalcinosis. Remember, medullary nephrocalcinosis में bilateral calcifications होंगे. ठीक है, पुट्टी किडनी यूनिलैटरल बायलैटरल कुछ भी हो सकती है. मेडुलरी नेफ्रोकैल्सिनोसिस bilateral calcifications. Why? Because it mostly happens secondary to metabolic diseases like hyperparathyroidism. ठीक है, पैराथायरॉयड एडिनोमा है, आप उसका अल्ट्रासाउंड या एक्सरे एब्डोमेन करोगे तो यू विल गेट मेडुलरी नेफ्रोकैल्सिनोसिस. ठीक है, सो ऑल दीज थ्री वर प्लेन, नीचे वाले 4, 5 एंड 6, फोर्थ, फिफ्थ एंड सिक्स्थ एक्सरे वर प्लेन एक्सरेज. प्लेन एक्सरे पर रीनल फॉसा में कैल्सिफिकेशंस कैसे दिखते हैं, आई हैव शोन हेयर. ठीक है, सो दिस वाज ऑल from our radiology discussion, and I hope I covered few important images. Not all obviously, because I don't want to make it a very long session. It's already been quite a lot of time. Radiology में just do important radiology images, just do this session, and main focus should be on your first prof subject. ठीक है, जब भी आप INI-CET की तैयारी कर रहे हो, आपके बायोकेमिस्ट्री, फार्मा, माइक्रोबायोलॉजी एंड एनाटमी, ये 4 big 4 subjects I call them. ठीक है, these should be very very strong. ठीक है, 60 questions out of your 200 will come from these big 4 subjects, and so main focus should be on these big 4 subjects. Radiology आप ऊपर से पढ़ो. ठीक है, so that's all from my side. Now we'll wrap the session for today. Thank you for attending.